Yeah, g'day, I'm Warwick Jones. I'm one of two palliative care physicians that are based at North Haven Hospice. Our role is to work with the community teams here at North Haven, but also to work with the teams throughout Northland that are delivering care to people who are dying at home, but also within the hospitals. That includes Whanau Hospital, Bay of Islands Hospital, Kaitaia Hospital, and working with the team over at Kaipara. The development of palliative care in New Zealand goes back a couple of decades now, and at the start of 2001 the government put out some direction about what they thought palliative care services in each DHB should look like. There should be an inpatient unit to look after the difficult palliative care issues. There needed to be a community service, but there also needed to be some sort of integration or some sort of service delivered within the secondary care hospital. North Haven Hospice and the NDHB sort of got together and nutted out what this might look like for Northland. And the plan that we came up with was, rather than trying to create a separate service within Whanau Hospital, we actually thought we'd use the skills and resources that already existed within the community services to actually come into Whanau Hospital, but also to come in to Kaitaia Hospital and to come into Bay of Islands Hospital, and to work alongside the teams that are in the hospital and know acute medicine, but to walk alongside them in issues related to someone doing the transition towards the dying phase, or managing dying, or how do we have those difficult conversations about actually more treatment for you would actually be more detrimental and harmful. And what we need to do is look at how we're going to manage you at home. So the community palliative care services have been invited in, as it were, to liaise with the acute services to help you guys manage those situations. One of the things that we realised is that we were getting referrals and they were coming from the GPs, which is fantastic. But a lot of people could have benefited also from palliative care, or those discussions around what the options are before they were back in the community. I was told that probably about 95% of the diagnoses of cancer occur in Whanau Hospital. And we probably had like a 4-day window when they were admitted to pick those people up. And so the palliative care service, the liaison palliative care service in Whanau Hospital, is an acute response service. When you need us, we should be able to respond within that 24-hour period. I mean, that's between Monday and Friday. The funding doesn't quite extend to after hours or weekends at the moment. But it's to be there so that we can start having those conversations with you as part of the management team, and also the patient and the family. We're also available to be a sounding board for the medical services and for the nursing services, a sounding board for the social workers and for the OTs and physios who are concerned about someone who is in the community. So even if you didn't necessarily want us involved all the time, you can use us as a resource. The other thing that we are quite keen on is knowing about someone who's going to be discharged and making sure that they have everything they need, whether it's working with your OT and physio departments to make sure that they have the right equipment, or what medication is best suited for that patient, what's the easiest and most reliable way to deliver pain relief, or how do we do that when someone's throwing up, and what do we do with confusion? Can we manage confusion in the community? And it's actually being able to put those things in place before someone leaves hospital, so that they don't have to come back to hospital. We must remember that our contact with patients and families, it's only brief, it's only a point on their journey, on their continuum. Most of their life, and probably most of people's death, should happen in the context of their community, of their family. With that in mind, palliative care, the palliative care community in Northland is committed to making available our assessments and our knowledge to not just you in secondary care, but also to the primary care teams. One of the ways of doing that is we've got a web-based patient management system that we use every day, but also that we've opened up with the permission of the patients to their doctors, to the specialists in the hospital, to the renal team, to ED. So when someone arrives in ED consultants can actually open up and read what's been happening with the patients in the community. The care of the patient has to be centred around the patient. About a third of people who die in Northland are referred to specialist palliative care services. But we're only one part of that network that's around the patient and family. You are one part of that network that's around the patient and family. It's really important we keep that in perspective. And what's important is that the patient and family are in control of that network and are in control of when they access the different parts. So we're not actually in competition. We're all part of the same mesh, the same kitty that's underneath and holds the family.